Hello, friends. I'm just giving a overview on this topic, nutrition in neurointensive care. So macro, micro, and immunonutrition. So that's the topic that I had to deliberate as part of a maniac conference that happened in Bangalore. So as you see, although it says in neurointensive care, the principles of nutrition in intensive care remains pretty similar. So we look into what are these three components of macro, micro, and immuno. So just a cartoon, I'm sure many of you would be seeing that re-emphasizes the need for early enteral nutrition. So the talks that I would be covering is defining malnutrition, and we understand that early enteral nutrition is crucial for recovery and its role. And we look into role of transpyloric and intragastric intolerance, and we look into briefly on immunomodulating nutrients, specific role in medical and surgery, and we look about ERAS. ERAS is early recovery after surgery, how pre-ICU and ICU optimization of nutrition is important. So, and I'll talk about micronutrition as part of this talk. So when you look at prevalence of malnutrition in ICU, so is it prevailing? So you need to look at the global statistics. So the overall malnutrition in ICU worldwide accounts for 38 to 78%. And even in USA, where you would think they're otherwise well-fed, the malnutrition is 30 to 50%. In Europe, it is around 37%. In Canada, it is around 31%. Latin America, it's around 30 to 60. And India, it's around 40. So which means malnutrition in India is very much prevailing. And globally, in ICU, malnutrition is something that is largely prevalent. And if you look at this data from India itself, so the malnourishment tends to proportionately increase with the associated comorbidities. As you see, the maximum malnutrition is present in cancer patients at around 86%, followed by chronic liver disease at 70%, COPD at around 65%, so on and so forth. So basically, the slide depicts as to how important it is to quantify the malnutrition that is prevailing, and at least 50% of your ICU patients would be malnourished. So targeting the nutritional goals become terribly important. So there are a lot of screening tools for critical care. I think largely we have agreed that the Nutrix score is a very important score to ascertain and quantify the malnutrition. So it takes into consideration the age and gives points accordingly. So I wouldn't expect anyone to memorize. You can go to MD Calcs, put up these variables, and you will get the score. So less than 50, 0, 50 to less than 75, 1, more than 75. So the older they get, higher the score. Apache less than 15 is 0, more than 28 is the maximum score of 3, and others in between. And they take SOFA score, 6 to less than 10 is 1, more than 10 is 2. And they also look into associated comorbidities. If it is more than 2, they get 1 point, 0 to 1 is 0. And they look at the time taken between the hospital admission and ICU. If patient is being admitted in the hospital for a longer time, so that gets more than, if it comes to ICU after more than 1 day of hospital stay, it gets more points, 1. So longer the stay, so higher the score. And they take interleukin 6 levels also, although this is not mandatory. So 0 to less than 400 is 0, more than 400 is 1. So these are the variables that are captured to determine the Nutrix score. Is it relevant? So they have done validation studies. So this study, I'm sure Haaland et al., I'm sure many of you know, he's a don of a lot of nutritional studies. So they have done this validation without IL-6, and they looked at if Nutrix score is 5 to 9, and it quantifies as a high score. What it tells you is these patients have poor outcome, higher risk of mortality, and higher risk of needing ventilation. 0 to 4 is considered low score, which means low malnutrition risk. So if any patients, you can do a simple Nutrix score at the outset. And if they come to 5 to 9, so there has to be more regimental incorporation of the nutritional goals in these patients. So enteral nutrition, why is it preferred in ICU? We all understand that enteral nutrition is the way to go because it maintains the gut function, and it tends to help to release some trophic substrates, and it helps to maintain gastric lymphoid tissue. So that is something that is important, and it helps to maintain the gut microbiota. So there are various advantages, release of trophic substances and maintenance of gastric lymphoid tissue and maintenance of gut microbiota. And it helps you to prevent parenteral nutrition and reduces your infective sort of a burden also. So the recommendation is if the gut is working, one has to consider using the gut. And early enteral, so what do we understand by early enteral nutrition? What is the definition? As per the ESPEN, ESPEN is European Society of Parenteral and Enteral Nutrition and Canadian Critical Care. Any patients who come to ICU, they need to be fed within 24 to 48 hours after admission. And ASPEN is American Society of Parental Enteral Nutrition and Society of Critical Care Medicine. Initially, they said you can feed between 24 to 72 hours, but now they revised it, and even ASPEN suggests that anyone who comes to ICU have to be fed within 48 hours, 24 to 48 hours. And Australian guidelines are even more aggressive. They suggest that you need to feed within 24 hours after ICU admission. So basically, this is a quality indicator. Any patient who is in ICU, if you have not fed the patient within 48 hours, it breaches the quality indicator and it may tantamount to malpractice. So when you look at the outcome studies, why early enteral nutrition? Does it have any clinical benefit? So there are huge trials done, and most of these meta-analyses are done by Haaland et al. He's a Canadian guy. If you see, this is a meta-analysis of 7. So they took 3 randomized controlled trials. They found no difference. But when they took all the 7 randomized controlled trials with 440 patients, early enteral nutrition was less than 48 hours, delayed enteral nutrition was more than. They found the infection risk was significantly less in the group which got early enteral nutrition, and that was statistically significant. How about mortality? Unfortunately, early feeding in the meta-analysis done by Haaland, where he took 14 randomized controlled trials, 670 patients, they did not find any difference in the mortality. So the main signal that came out of all the trials was it reduces the risk of infection. So that's why we have to feed these patients to reduce the infection burden and improve the outcome. And this is another study which came from Germany and Netherlands. These are in a systematic review. This is the latest one which came in 2016. As you say, early enteral nutrition reduced the ICU length of stay. Although it did not have any difference with regards to hospital length of stay or mechanical, but ICU length of stay significantly was less in patients who had early enteral nutrition. Okay, so now the question is, route of enteral feeding in critical. So always it has to be a gastric feeding, and bowel sounds is not something that you pay attention to. If someone is not able to tolerate gastric, then you may have to think of at least post pyloric to make sure that feeding is resumed. So keep an eye on the aspiration, and there may be risk of gastroparesis and feed intolerance. Can be determined by high gastric residual volume that may be, but although GRV is not something taken as a criteria to stop feeding, one has to persevere and continue unless there is a continuous high GRV load. So these are certain things that you may have to bear in mind. And the ASPEN and ESPEN guidelines suggest that bowel sounds, because post-operatively, so the message is loud and clear that one should not look into bowel sounds as a determining factor to start nutrition. So bowel sounds is something it's a myth. One should not base your nutritional initiation based on the bowel sounds. Even if it is there or not, one has to initiate in these patients, and trophic feeds at least has to be initiated. And when you talk about ERAS, ERAS talks about early recovery after surgery. Basically, this is in a non-neurosurgical patients. Basically, the emphasis is on adequate analgesia for good recovery process and early extubation. And all these have shown, and nutritional optimization has shown to reduce the length of stay and early mobilization. All this has shown to reduce the risk of ileus, and feed tolerance becomes much better if your analgesia is taken care of, early extubation is taken care of, and early mobilization is initiated. So the nutritional goals are met easily with reduced ileus is what has been activated. So as I already said, so tolerance and adequacy of enteral feeding has to be looked at by keeping in mind the risk of aspiration, gastroparesis, intolerance. And it is suggested and recommended that continuous tube feeding is something that needs to be encouraged with a proper gravity bags, and the feeding, ideally, the recommendation is to do continuous feeding. So there are ready to hang bottles that are available, and that gets B3 recommendation, where this can be easy and there is no contamination, and this is something one could incorporate. These are easily available now, and this is something one can bear in mind. And if there is feed intolerance, one should adopt the usage of prokinetics to enhance the feed tolerance, and propped up position with a head end elevation of at least 45 degree helps in good sort of a feed tolerance. And using of chlorhexidine mouthwash also is sort of suggested in all the patients who are enterally fed. So basically, these are some of the guidelines that have come from ASPEN and ESPEN that to facilitate good feed tolerance. So head end elevation, use of prokinetics and chloroxine mouthwash and continuous feeding with gravity bags or ready to hang bottles need to be thought of. And what about in patients who are hemodynamically unstable? Even in patients who are hemodynamically unstable, enteral nutrition at a low dose uh, has to be initiated, especially who are on low dose vasopressors. But if vasopressors are slowly and gradually increasing, then enteral nutrition may have to be withheld until hemodynamic stability is attained. So patients with MAP less than 50 millimeter, so lactate has to be monitored and feed initiation has to be thought of once hemodynamic stability is attained. And obviously, one would continue to watch for increasing in the gastric residual volume because when they're very hypotensive, our understanding is the bowel perfusion is not happening and feed intolerance tends to happen. So that is something one needs. So that's why you initiate the feeds once lactate levels have settled, your gastric residual volumes have come down, and hemodynamic stability is maintained. So this is a study which came in American Journal of Critical Care in 2010, where they showed feeding in hemodynamically unstable patients, where they showed early feeding this is in hemodynamically unstable patients, where ICU mortality and hospital mortality are significantly less. The blue one is the patients who were fed early, and the orange one was fed late. This is in hemodynamically unstable patients. They found mortality was better in patients who were fed early despite their hemodynamic instability, once of course having attained some stability after resuscitation. So that's about the general principles of nutrition. So we'll just talk about what do we understand by macronutrition in ICU. Macronutrition is all about how much calories we give, how much proteins we give, how much carbohydrates we give. So the whole emphasis is on calories and the protein intake. So if you look at traumatic brain injury, the protein that is sort of suggested or recommended by Aspen is 1.5 to 2.5 grams per kg per day. And in other critically ill patients, it's 1.2 to 2.5. And if you look at the total energy, it's around 20 to 30 kilocalories per kg per day. So the general recommendations or the ballpark is protein, we give 1.2 to 2 grams per kg per day. Strong recommendation with good level of evidence. Calories, we agree upon 25 to 30 kilocalories per kg per day. If someone is hypercatabolic, then where your calories is to nitrogen is 120 is to 1, you have to use Toronto formula. So our general understanding is the first 2 days of ICU, we target around 12.5 kilocalories per kg. At 3 to 7, it's a more of a step ladder approach for calories and protein. I'll show you the next slide. So initially you start low at 12.5 kilocalories. Day 3 to 7, you can go up to 18 kilocalories. After day 7, you can target 25 kilocalories per kg. So the most sort of agreed upon approach to macronutrition is you can start with 25% of your nutritional goals on day 1 and reach to 50% on day 2 and reach to 75% on day 3. So this is a accepted approach to sort of stagger your nutrition and increase and slowly and gradually increase it in a step ladder way. But after day 5 or after day 4, one should aim to attain 100% of their calorie needs. And at that point of time, you can increase the protein to 1.3 grams per kg per day. And post ICU phase, after they shift out of ICU to the ward or to the rehab center, one has to target about 30 kilocalories per kg per day. And if you see, the protein intake is sort of cascaded up to 1.5 to 2 grams per kg per day. And post hospital discharge, you can even go up to the calories more than 35 kilocalories per kg per day, and protein you can go up to 2 to 2.5 grams of protein per kg per day. So I think this is a most acceptable sort of an approach where you start with 25% on day 1, 50% on day 2, 75% on day 3, and reach to 100% on day 4. Protein also you sort of keep cascading up from 1.3 grams at day 4 to up to 2.5 grams on post-hospital discharge. So this is sort of most acceptable approach for macronutrition. And what about daily electrolyte needs? So obviously all these electrolytes come from the diet, enteral nutrition that is given. And these are the sort of a dietary requirements of calcium, magnesium, phosphorus. Well, you don't need to memorize, look up the table. So, but what needs to be understood is any diet should constitute all these sort of electrolytes, which also form a part of your macronutrition. Okay, let's move on to micronutrition. So, what do we understand by micronutrition? Micronutrition is in addition to macronutrition, which is calories, carbohydrates, fat, and protein, we need to give vitamins and we need to give minerals. So minerals are trace elements. So that constitutes micronutrition. So micronutrition is a combination of vitamins and uh, vitamins and the trace elements. So the vitamins that we tend to give is all these components. So any of these vitamins have to be kept in mind. So these constitute the micronutrients. So thiamine, riboflavin, niacin, all these come in the enteral nutrition in any diet that you give. These are all part. And when it comes to the micronutrients, minerals, so these are the minerals that any patient in ICU would need, and all this comes from the enteral diet that one will be providing. So these are just look at the last column. So these are the recommended sort of a trace elements that patients need. Zinc 2 to 5 milligram, copper 200 to 500 micrograms, manganese, chromium, and selenium. So what are the role of micronutrients in nutrition? Micronutrients are needed for metabolism and utilization of macronutrients. So the whole understanding of micronutrients is they are needed for metabolism and utilization of macronutrients. And as I said, micronutrients include the vitamins and minerals, and both are crucial for the nutritional goals. So provision of micronutrients in parenteral nutrition. So even the consensus paper suggests that these nutrients have to be added on to the parenteral nutrition that someone is getting, and daily IV for administration of trace elements and vitamins is something that is needed for these patients. So when we talk about trace elements, it's an essential part of micronutrients. So, and we already spoke about all these minerals that form part of the micronutrition. So zinc is very important. So iron is needed for obviously hemoglobin. Zinc is needed for growth, healing, and immune function. And copper is needed for collagen formation and connective tissue sort of a formation. Manganese is needed for metabolism of all this arginine, pyruvate, and superoxide. Chromium is needed as a part of the insulin receptor, so it is needed for insulin uptake, so on and so forth. So the minerals in body regulate metabolism. So, and these minerals are not synthesized naturally, and they need to be provided from external. And these minerals are needed for vital body functions, including metabolism, tissue repair, growth, and development. So these are mainly just to summarily keep in mind that all these trace elements cannot be manufactured in the body, and they need to be provided from outside. And these are needed for the metabolism of the macronutrients. If you understand that, that should be good enough. So when you talk about critically ill, they have pre-existing sort of a micronutrient deficiency if they have, and inadequate or inappropriate administration of micronutrient deficiency is something that can be present in critically ill patients, and it can lead to adverse biochemical and enzyme function, leading to organ dysfunction, poor wound healing, and muscle weakness, and neuropsychiatric disorders. So most critically ill may have some sort of a micronutrient deficiency, and this needs to be replenished in these patients. And micronutrient levels must be restored, and reserves needs to be replenished. So we'll just talk very briefly about the key micronutrients. Zinc. See, all these micronutrients or the trace elements are needed for certain enzymatic metabolism. So they are needed for all these. Zinc is needed for all these enzymes, carbonic anhydrase, peptidase, alpha. So all these enzymes need zinc for their activity. So basically, zinc is needed for metabolism of protein, metabolism of carbohydrate, metabolism of lipid, and metabolism of the bone. So if there is a zinc deficiency, they will have depression, alopecia, stomatitis, anorexia, and poor wound healing. So these are some of the manifestations of zinc, and it can also lead to immunosuppression. And zinc deficiency also can cause diarrhea, or diarrhea itself can lead to the zinc depletion in the body. So this is the skin manifestation of zinc, and many a times in ICU you may see certain patients having this. So they can have clustered erythema and plaques in chronic zinc deficiency. which we call it as acrodermatitis enteropathica. So what about copper? So like any other trace elements, copper is needed for metabolism of all these enzymes, ceruloplasmin, monoamino oxidase, so on and so forth. And copper is needed for metabolism and building of the collagen tissue and the bone metabolism. And copper is needed for good bone marrow function and production of all the hematopoietic stem cells or the bloodlines and the synthesis of all the bloodlines in the bone marrow. Copper is needed. So if there is deficiency of copper, it can lead to pancytopenia, or it can cause anemia, leukopenia, so on and so forth. So this is a very important aspect as to why copper is important. What about chromium? Chromium is needed for as a insulin for effective functioning of the insulin receptor. So it is needed for metabolism of protein, carbohydrate, lipid, and collagen tissue. So deficiency of chromium leads to glucose intolerance and increase in the free fatty acid and negative nitrogen balance. And it can lead to reduction in the respiratory quotient of the lung, and it can lead to the weight loss, and it can lead to peripheral neuropathy. So chromium basically is needed for sensitization of the insulin receptors and glucose uptake, and deficiency of chromium can lead to glucose intolerance, weight issues, and peripheral neuropathy. What about selenium? Selenium is needed for metabolism of these enzymes, and mainly it is needed for good thyroid function, and selenium is needed for conversion of T4 to T3. So deficiency of selenium can lead to cardiomyopathy, can lead to skin changes, and can lead to myalgia. So what about manganese? Manganese is needed for metabolism of these enzymes, arginine, pyruvate. So, and it is needed for metabolism of carbohydrate, lipid. Mainly manganese is needed for reproductive activity and bone metabolism. And deficiency lead to deformity of the bone. It can lead to fatty accumulation in the liver and increase in the ALP levels in the liver. And it can lead to reduced activity of the beta cells. And mainly manganese deficiency can lead to infertility and sterility. So this is an important function of manganese. So that's about your micronutrition, which is mainly vitamins and trace elements. So very briefly, we'll touch about the immunonutrition in the ICU patients. So what do we understand by immunonutrition? These are certain agents which are known to improve your immunity. So there are certain agents which cause immune stimulating like arginine and glutamine. And there are prebiotics and probiotics which sort of improve the digestive tract health. And there are anti-inflammatory agents like epsilon pentoic acid and linoleic acid. So, and antioxidants, vitamin E, A, C, and selenium. So these are immune modulating or immunonutrition, what we say. So in a normal inflammatory response, there is a good balance between pro-inflammatory and anti-inflammatory sort of agents in the body. So when there is a pro-inflammatory cascade that is set in, there is an uncontrolled inflammation that happens, which leads to SARS, acute lung injury, and sepsis. So for this, so the hypothesis is epsilon pentoic acid and gamma linoleic acid helps to control this pro-inflammatory cascade is what the scientific hypothesis is. And when there is a overwhelming anti-inflammatory sort of a cascade that tends to happen, that can lead to immunosuppression. And arginine is known to prevent this anti-inflammatory cascade. And arginine is shown to be helpful as a scientific hypothesis in surgical patients, polytrauma, and in enhanced wound healing. But is there evidence? So glutamine, let us look into all the immunonutrition that is available in the market. So glutamine is a precursor of synthesis of nucleotides, and glutamine is a fuel that is needed for the replication of the cells. And glutamine in the liver is converted to glutamate and ammonia. It is known to enhance stress protein response, attenuate inflammation and oxidate stress, and it improves the tissue metabolic function. But is there any evidence? So the Society of Critical Care Medicine and the Aspen 2016 guidelines suggest that glutamine has limited effect, and glutamine is not to be routinely recommended for traumatic brain injury or post-surgical or trauma patients. So there is no robust evidence for the role of glutamine in ICU. What about arginine? It's a conditionally essential amino acid. Arginine deficiency can occur. So arginine is shown to have a trophic effect on the isthmus, and arginine is something that is needed for proliferation of lymphocytes and good sort of an immune response. Is there evidence? So study shows there is routine usage of arginine has no evidence, and it is known to increase the inhibitory nitric oxide synthase leading to vasodilation. So L-arginine is used in trauma and polytrauma along with fish oil. Some of the studies have shown it to reduce the length of stay and reduce the risk of infection. So this is some of the evidence, but it is not routinely recommended for our ICU patients. What about immune modulating fatty acids? As I said, eicosapentaenoic acid and gamma linolic acids are used. So N3 fatty acids is known to reduce the inflammation by getting converted to N6 fatty acid. It is known to modulate inflammatory conditions in post-surgical patients, in trauma, in traumatic brain injury, cardiac surgery patients, and inflammatory bowel disease and cancers. It is shown to modulate inflammation, but Society of Critical Care Medicine Aspen 2016 guidelines do not recommend routine usage of immuno. So all these immunonutrients, arginine, glutamine, and these fatty acids, they are not recommended as per the guideline for routine usage in any of these patients. And what about immune modulating fatty acids like gamma linolic acid, shown to reduce inflammation with N6 fatty acid and shown to modulate inflammatory conditions in SIRS, cardiac patients, acute lung injury, ARDS, and inflammatory bowel disease, but not shown to have a sort of a benefit conclusively, and they're not routinely recommended. So the key points of nutrition in ICU is use Nutrix score to identify critically ill patients with malnutrition. Enteral nutrition has to be encouraged in all ICU patients within 24 to 48 hours as per ISPEN recommendation, ASPEN recommendation, Canadian recommendation, and Australian all suggest enteral nutrition to be initiated within 24 to 48 hours. And there are 14 randomized controlled trials which show that it reduces the risk of infection, although it may not influence mortality to a great deal. Even if patient is hemodynamically stable, after attaining hemodynamic stability and after the lactate levels have come down, one needs to initiate enteral nutrition within 24 to 48 hours after attaining hemodynamic stability. And one has to keep monitoring the gut function to see for the feed tolerance and watch out for aspiration, feed intolerance, and gastroparesis. Immune modulating agents not routinely recommended by any of the guidelines. Strong recommendation, good level of evidence that not to be routinely recommended. All these arginine, glutamine, and fatty acids not to be routinely recommended. And within 72 hours, try to attain 50 to 60% of the nutritional goals. After 72 hours, day 4, you can try to target up to 100%. But 72 hours, try to target up to 60% of your enteral nutrition. And combination of enteral nutrition and parenteral is not routinely recommended because there are some studies which have shown utility, but this is not routinely recommended. And it is a strong recommendation with a moderate level of evidence. I think what you can follow is this chart. Day 1 to 3, try to have a step ladder approach to cascade your nutritional goals. Day 4, try to achieve 100% with protein of 1.3. And post ICU discharge, try to target 1.5 to 2 grams proteins per day. And post hospital discharge, try to target 2 to 2.5 grams protein per kg per day. So thank you, friends. So I invite you all to submit your valuable work to a Journal of Acute Care, which comes out every 3 months. You can visit my website. So thank you. Thank you.